What's up, Facebook? So this video is for Robin, but really it applies to anybody. So Robin shared a story recently in which before her knee replacement, she had a really unstable knee. She had some ruptured ligaments from old traumatic history, probably sports-related trauma, and she had her knee replaced. Prior to the knee replacement, she would feel like her knee would want to buckle or give out. She'd feel like it was just loose inside the joint. And so when she got her knee replaced, she thought she would feel more stability within the new joint. So let's talk about it for a second. When you look at the structure of the knee and the way the knee is really designed to move, you know, there's two primary movements. Like day one in PT school, we talk about one is a pivoting motion and one is a gliding motion. So in order for the knee to go from fully extended, let's put it this way. So let's pretend this is the lower leg bone, this is the upper leg bone. My knee is straight here in this position. In order for my knee to bend, two things have to happen. One is the ball on the top, the femur, has to roll, and at the same time, it has to slide. So another way I could look at it is like a cup. It has to roll and it has to slide. The ACL, the anterior cruciate ligament, is usually what holds that bone so that as the knee starts to flex, the bone doesn't drop off the back. What happens is the ACL kind of pulls that bone forward to stay on top of the tibial plateau. If you don't have an ACL prior to surgery, you still don't have an ACL after surgery. So that it's reasonable that you still have some of that instability and joint laxity. The other part that nobody really talks about is the tibial pivot. We call it a screw hole mechanism, a locking mechanism, but basically when your knee goes from full extension to about 20 degrees of flexion, what happens is the tibia normally rotates. And so that's where you're going to experience the highest level of just kind of unease and instability, is with that going from full extension, where you might feel that tibia want to move or the femur want to move, or going from full extension to like 10, 15, 20 degrees of flexion. Especially now, Robin's doing phenomenal. I don't know that I've ever seen another person get a knee replaced and do this well. She's not my client, but she shared a lot of her story on Facebook and just blowing like expectations out of the water. But that being said, we're not all gonna do that well. And so it's reasonable 4 months, 6 months, 8 months, you still have swelling. Swelling is gonna increase some of the looseness in the joint. It's like if you have a lot of swelling, the joint's tight. If you have no swelling, you know, the joint is looser, and then there's all those shades in between. So I'm gonna show you my 3 probably most favorite ways to work on knee stability when you legitimately have just kind of an unstable knee. And we're just gonna do it here in this exam room, no equipment, nothing special. So stick with me. I'm gonna try to speak up just because now the camera is kind of far away from me. But option number 1, so let's say it's my right knee. My right knee was replaced, I don't have an ACL, it just feels a little bit kind of wonky and unstable. So one of my favorites is, I find something that I can touch for balance. It could be a counter, it could be a wall, it could be a doorknob, it doesn't matter. But I'm just something that I can touch for balance on the same side as the leg I'm standing on. Even if you just have instability on one leg, I would do both legs and I'll show you, but I stand on the one leg, I touch the counter for a little bit of balance. I usually lift my opposite side hand up high toward the ceiling so my knee is fully extended. I'm reaching up tall. You can even go up on the toe if you want to make it a toe raise with it. And then as you come down, so I bend at the hip, I bend at the knee, I bend at the ankle, I bend at the trunk, and I touch my toe in front of my, well, I touch my toe. I touch the floor in front of my shoe. Let me see if I can back up so you guys can see a little better. Okay, so then I'm gonna switch sides just because camera. So I reach up tall, maybe do a heel raise like I'm trying to touch the ceiling, come down, hip, knee, ankle flexion, touch the floor in front of the toe. This is the motion. Now what's nice about a motion like that is that you can kind of decide if you want it to be more knee, more of a squat, or you want it to be more hip, more of a deadlift. So in other words, kind of close up. So I can flex my knee and make all of the motion come from the hip, or I can make more of the motion almost like a single leg, like a lunge, more of the motion come from the knee. Totally up to you. But typically what I do, those joint angles replicate walking and running. And so you're building repetitions of the knee going from full extension, 0 degrees, to 15 or 20 degrees of flexion, under load, single leg support, which would be comparable to the swing phase of walking or to the running cycle. And the idea is we're giving the brain and the nervous system time to adapt and get comfortable with that instability, because it will figure it out, right? We can't tighten the ligaments, we can't tighten the joint, but we can at least train the nervous system to understand what's going on and anticipate it a little bit and build that stability. We're also building a little strength, a little endurance. You know, it's one thing to be fresh and the first 10 steps you feel great, but as you fatigue, as you start breathing heavy, as you start sweating, kind of you lose some of that proprioception, the sense of, so proprioception, for those who don't know, without seeing my hand, I know what my fingers are doing because my joints kind of give my brain the information, right? I know I'm touching thumb and index finger, thumb and middle finger because I can feel it. After an injury, it's not uncommon that we lose that sense of proprioception. And so one of the best ways to retrain a person to return to activity, whether it's sports or walking or work, is to focus on improving proprioception, improve the quality and the feel of the brain information system so that they can, if I put them in a position and then they move away, they can reproduce that same position without having to look at it. So proprioceptive training is probably the main goal of the 3 exercises that I'm doing with you here today. So we've got the single leg floor to overhead reach, right? And so I just do it one more time. I reach up on my tippy toes, come down, touch the ground, reach back up. Awesome. My second one, which is just a little bit easier, would be, again, I've got something kind of between me and my support leg now. I'll do a little hip swing, let's call it. Hip, knee, ankle, everything is relaxed. But what I'm going to do is I'm going to go up on my toe when my foot is forward, and I'm going to come down into a little bit of a knee, hip, ankle flexion. So it's almost like I'm kicking up nice and high, but the idea is, again, I'm going through that dynamic stability. And what you should see, if you can do this in front of a mirror, like I'm doing it in front of the camera, is when I'm up, my leg is nice and straight. I'm going to try and hit straight on. But as I come down, we don't want that knee to collapse in, right? We want to kind of keep it over the second toe, maybe a little bit wide if I had to choose. But what's happening is I've got the tibial rotation, the terminal knee extension. I'm building some strength, I'm building some endurance. Just from that, my quad's already a little bit burny, right? And so 10, 15, 20 repetitions. You do the left side, you do the right side. I always touch the supporting wall opposite the leg that I'm standing on. This way I have that kind of crossbody stability, just like you would typically use a cane, opposite the injured leg, or when you walk, if my right hand goes forward, my left foot's going forward. It's just that crossbody pattern that humans use to move in space. Finally, the last one, I usually like to kind of scale it back down a little bit if I'm going to do something. I try to look at the hip and the ankle to build stability for the knee, right? And so we know from clinical research, any human, any adult at any age, really should be able to stand on one leg, full balance without kind of lots of wobbling for 20 to 30 seconds. Okay, so I'm here just quiet standing. Now, you can take this and apply a little bit of a knee bend. You can take this, apply full knee extension. I know it's kind of hard to tell here. So let's say that's full knee extension right there. I'm not wrapping my other leg. I'm just picking it up off the floor. You can see I just came from a workout, so I'm kind of wobbly. This is a little bit of knee flexion so that I'm building stability, in this case static stability, in those positions that I've been struggling with, finding challenges in. And so I might do a 30-second eyes open, single leg balance, and then I might do a 30-second eyes closed, single leg balance. Of course, the fear is if you're doing this by yourself, you don't have a spotter, you know, you want to find something like a corner so that if you needed to, you could kind of touch those walls for stability. Countertop, hallway, just something to keep you safe. You know, the first priority of any kind of training or rehab is keeping you safe. The second priority is improved performance. We can't get to number 2 if we mess up number 1. So keeping you safe, keeping you injury-free while you're rehabbing should be every physical therapist's goal and every patient's goal. So Robin, everybody else, I hope this video helped. I hope the explanation of kind of, you know, that rolling and gliding with flexion, but then also the tibial rotation kind of shed some light for those who don't know that on how the knee structure is supposed to work and why for some people without an ACL it feels unstable, especially as the swelling goes down and the range of motion increases. You know, our bodies are phenomenal pieces of equipment. And one of the things that I think we take for granted is our bodies understand how to heal itself, right? How to keep us going. If we have damaged tissue, if we have an injury and you know, we don't seek out medical care, our bodies will typically lay down scar tissue. You're all acutely aware of scar tissue, and essentially fuse the problem if it's a joint problem, right? So many of my patients with low back pain will come in their 70s and 80s and their lumbar spine is pretty much fused itself because we think, oh, I'm stiff, it hurts, stiffness is pain. Really, stiffness and the elimination of movement is our body's way to heal itself in many cases, you know? So when we're looking at instability, our body will do what it can to find alternative ways to build that stability back, whether it be the joints above and below, whether it be trying to fuse the joint. Now your body can't fuse a knee that's been replaced, but scar tissue around it. And so it's a balancing act because you're trying to regain, like Robin has amazing range of motion, you're trying to regain range of motion, but with that, you're losing stability. Okay, so you hear me say it all the time, the Goldilocks effect. We want not too much, not too little. We need it just right in the middle. And so, again, please keep the comments, the questions coming. The engagement has been amazing. I hope this video provides you with some value. I'll catch you guys in the next video. Thanks for watching.